Hello everyone, today we're going to talk about radiographic contrast as part of our RADS.102 course. Remember, we've got different properties that create the radiographic image. We've got our photographic properties, which are image density and contrast, and then we also have our geometric properties, which are detail and distortion. In our last unit, we talked about density. We're going to move on now to contrast. So when we talk about contrast, image contrast is the difference between adjacent densities or IR exposures. If we look to the step wedge on the right, you can see that each step would have increasing amounts of density. It's that difference between those densities that we call contrast. And the range goes from clear white on a radiograph through various shades of gray all the way to black. Remember when we studied the H&D curve, we saw that when you were in the toe region of the curve, those are the lighter densities. So if you had a 0.0 optical density, it would be totally clear on a piece of film. All the way up to 4.0. 4.0, remember, that's in the shoulder region of the curve. And 4.0 would be your very blackest densities. So once again, contrast is simply the differences between the densities that are on your radiograph. Now when we talk about digital imaging uses a couple of terms that are for contrast. One of them is dynamic range. And we define dynamic range as the contrast as it is displayed on the soft copy monitor. So what you're looking at on the screen when you see these differences in density. So it's the range of brightness. Now remember, in the digital world, density and brightness can be kind of thought of as synonymous. Okay, they're not exactly the same thing, but they're synonymous. So it's the range of brightness of the display monitor for light emission. So how much light is coming out of various parts of your monitor? That varying part, or those varying amounts of light coming out of the different areas on the monitor, which correspond to different anatomical regions, is what we refer to as dynamic range. Now your window width is related to the window level. Now remember, in the unit on density IR exposure, we determined that density and IR exposure, the term that you use for that would be the window level. Now we're going to talk about, once you get to that level, how much can I open or close the window, giving me either more shades of gray or less shades of gray. So window width is a digital processing determinant that produces or changes the differences in the brightness. As far as density is concerned, density is pretty straightforward. What a lot of students find more difficult is radiographic contrast. So contrast is the most difficult of the prime technical factors to evaluate and to adjust. Although contrast and density or IR exposure are unrelated, I want you to consider contrast as an independent factor. Okay, so of course, you have to have differences in densities to create contrast, but oftentimes when you're talking about the various factors as they relate to the radiographic image, and we think about what we learned for density, and now we're learning about contrast, sometimes it may seem that they can come into conflict. So my advice to you for an ease in understanding the concepts of contrast, I want you to take what you've learned about density and IR exposure, put that knowledge into a box and put it on a shelf in your brain. Okay, so basically we've learned it, we're not going to forget it, and we're able to recall it. So the knowledge is there for recall, but you won't be tempted to overthink concepts of contrast in relation to density or IR exposure. I know this sounds strange, but trust me, it will save you a lot of confusion as we progress. When we describe contrast, contrast is the differences between densities when there's very large differences. The image then is considered to be what we call high contrast. So if the differences are great, the image is said to be highly contrasting. When the image has many discernible shades of gray, the image is considered low contrast. So big differences in contrast, high contrast. When we have many different shades of gray, we say that image is low contrast. As far as contrast is concerned, in most instances, when we look at a radiograph or even look at a picture and image, low contrast provides more information, even though the high contrasting image is often more pleasing to the eye. So when we look at the dog down below, we can see that A gives us a lot of variations in the amounts of gray that is in this photograph of this very cute little dog here. In B, what are we doing? We're taking more of the grays out. It's giving me a little bit more black and white image. And then in C, we've taken pretty much all the grays out, and we're left with more or less a black or white image. So at first glance, for many people, C might be the more appealing, that very dramatic change between black versus white. However, when we look at this and we look at these three pictures of this dog, what do we notice? We notice there's more detail of the dog in A than there is in C. That amount or differences in the gray tones allows us then to see more detail. Some anatomical structures require low contrast imaging and some require high contrast imaging. I've got various radiographs down at the bottom. So if you look at this, one region, for example, is the chest or the thorax area. If we are imaging the chest or the thorax and we're interested in the heart or lungs, this would be an image that we would want more low contrast. We want to see more grays. Why do we want to see more grays? We're pretty much interested in that very delicate parenchyma of lung tissue. And you're only going to see the lung parenchyma, which shows up as little bits of gray scattered throughout the lung fields. You're only going to see that when you have a lower contrasting image. If we go to the second radiograph, same body part area, we're still looking at the thorax, but what we're noticing is that it's a little bit more black and white, okay? And when we look at this, why do we want more black and white? Well, we'd like to see the ribs, which are going to show up as more white, contrasted against a darker background, which would be, of course, the air in the lungs. We're not interested in the lung parenchyma because we're interested in seeing if there is a fracture, for example, to the rib itself. When we look at the abdomen we want to be low contrast, lots of grays. And what's the reason for that? Well, we want to see, for example, over in the right upper quadrant, we want to see the liver. We'd like to see the shadows of the kidney. We'd like to see those psoas muscles coming down. And of course, we're going to see some black and some clearer areas because we need to see any gas, for example, that might be in the bowel itself, or of course, we need to see the bony structures that make up the abdomen, the spine, and the pelvic area as far as image itself along with the ribs and a little bit of the hips, right? Okay, we don't want to, for example, ever clip the symphysis pubis on our KUB. Extremities, like the hand, for example, that's pictured over on your right, we want that to be high contrast. Okay, we basically want to see soft tissue bone, right, and not a lot of grays in between. Okay, we're mainly interested in assessing the bony areas when we take extremities and seeing if there's any possible fracture. Just as a little side note here that got labeling on this hand x-ray here. You could either stop the video, or if you go onto Moodle and you click on the PowerPoint, you can stop it there. I'd really like you to review, if you've forgotten, the structures that are labeled there. So can you identify those labeled parts of the hand? And if you can't, then you need to review the anatomical structure of the hand in Merrill's or in Mallet. Look at contrast terminology. Whenever we talk about contrast, we talk about what's called the scale of contrast. The scale of contrast is your actual number of shades of visible density. So when we look at this over on the right here, and I want you to notice each step and being able to see each step separately. The numbers down at the bottom represent kilovoltages that were used in radiographing a pentrometer. Remember, a pentrometer is that aluminum step wedge. So when we use a lower kilovoltage, what do we notice? We notice that we're going from black, where I can see density within many of the steps there, and then all of a sudden I can see density getting less and less, and then I can't really make out the difference in steps anymore. So with 40 kilovoltage, you're going more from black to white very quickly. So we say that this would be a high contrasting image. Notice what's happening is as you go up in kilovoltage from 40 to 50 to 60, 70, 80, 90, all the way to 100. What are you noticing? On the 100 there, you're really seeing more of the steps, the individual steps filled with density. So we call that a long scale of contrast. So from these series of images of these different step wedges taken at varying kilovoltage, we can deduce that low kilovoltage gives you a more black and white image, high contrast, whereas a high kilovoltage gives you many more shades of gray, which we would then say is low contrast. So high kVp, long scale of contrast, or low contrasting image. Another thing with contrast that students often have trouble with is terminology itself. When we think about the term high contrast, what does that mean? Few shades of gray, which means if there's few shades of gray, what makes up a radiographic image? White, grays, black. So if there's few shades of gray, meaning you're going from white to black quickly, we say that that's high contrast or increased contrast. As we see on the step wedges over on the right, you get the higher contrast with low kVp. You can also call this a short scale contrast. So high contrast, low kVp, short scale of contrast. So high contrast, low kVp, short scale of contrast. And in the digital world, as far as contrast is concerned, high contrast would be a short or narrow window width. We're going to talk a little bit more about window width. In fact, a lot more about window width in our digital imaging class. But for right now, we can think of high contrast as a narrow window width. For low contrast, it's just the opposite. So low contrast, we've got many shades of gray. We can say there's decreased contrast. We get this by looking at the step wedge. We can see this with high KVP. And because many of the steps now are filled up with varying amounts of density, we say this is long scale contrast. Long scale in the digital world is a large or a wide window width. I think about having like an actual window. If I had all these different amounts of densities outside of the window, and I didn't open the window up very much, okay, it would give me a short scale. It wouldn't let many of those variations in. If I opened up the window wide, I'd have a flood of these different densities coming in, and that would give me then a large window width, a lower contrasting image. So when we talk about image contrast, remember, we're talking about really two things. We're talking about the image receptor itself and the patient. So we say that image contrast is equal to image receptor contrast, and subject or patient contrast. As far as digital image receptor contrast is concerned, the primary method for changing contrast on acquired radiographic images is through manipulation of the window width that we were just talking about. So what really happens? Well, after the remnant radiation is transmitted through the patient, so we've taken the x-ray, the radiation is in the patient, some of it gets absorbed through photoelectric interactions, some of it gets scattered by Compton, and some is transmitted. So whatever's in that remnant beam, after that remnant beam is transmitted through the patient, it interacts and is collected by either the computerized image receptor or a digital detector. More often digital detectors nowadays. We're kind of getting away from using CR, moving into that DR realm. The information acquired then, so whatever radiation either strikes or doesn't strike the different elements of the detector or the IR, the information acquired is then sent to the system's computer for processing. And we're going to learn much more about this in the digital imaging class, but basically what is formed from the amounts of radiation coming off your detector is something called a histogram. So your image, you create it by the technical factors that you set up. You create a histogram. And the other factor that's going to be involved is what's called the LUT, or the lookup table. So what is the histogram? Well, the histogram, if we look over to the right, and here we've got a chest x-ray. A histogram is a graph that the computer creates to assess the minimum and the maximum values of the radiation that are recorded within that image. And the shape of a histogram will correspond to specific anatomy and technique that's used for the examination. Now, what do you do? When you take an x-ray, you have to click on or indicate somehow the body part that you are going to be radiographing. When you do this in the computer, it sets up what's called a reference histogram, something that the computer is going to look at. The acquired histogram, what you're going to get, is based on the technical factors that you set up. So you've got this reference histogram that the computer it's waiting. It's saying, okay, I've got a histogram here for a foot. This is basically what it should look like. You take the image. You create another histogram. The computer then looks at the reference histogram based on what you selected when you started the exam and the new histogram that it has been created when you took the image, and it's going to compare the two. What's going to happen then is if we have a wide histogram, okay, wider histograms give you higher contrasting images, and narrow histograms give you lower contrasting images. So histograms are going to, once again, going to take, or the computer is going to take the minimum and maximum values, take a look at them. Where are they at? How many photons did it take to achieve that? So the area over on your y-axis, and then your receptor exposure on your x-axis. And it's going to compare what you've taken histogram-wise to the acquired histogram, or the one that you took the acquired to the reference, I should say. So once the computer looks at that, then it's going to utilize another method that's really the one that's more involved with the contrast, and that's called your lookup table. So your acquired histogram was looked at by the computer in relation to the reference histogram, and it's going to merge them. Okay, so it's going to try and make whatever histogram you took into what would be the ideal histogram. In doing that, it's also using what's called a lookup table. And with the lookup table, once again, it's a computerized adjustment for contrast. The computer looks at the data that's been received, that data from the detector, and then adjusts it to the ideal contrast for a given anatomical part. So you've got this histogram as a reference, and then you've got a set of factors that are in a, quote, lookup table, which tells the computer this is the perfect contrast that there should be for this image. So you can't really determine this much anymore on DR because the image comes up pretty spontaneously after you take the exposure. But those of you that have worked with CR or in clinical sites where they still have CR, when you take your initial image and it comes up on the screen, it looks kind of very dull and washed out looking. If we look at this picture here, and then the computer says, okay, well, I'm going to adjust the histogram. That would be the ideal one. And then I'm going to look at the contrast and I'm going to adjust that. And I'm going to do that by using my lookup table. Basically, what the computer is doing is windowing. So that original kind of washed out image, all of a sudden it turns into a nicer looking image. So once again, if you've worked with CR, you've seen this. Okay, it's happening in DR too, but it's happening very, very, very quickly. Now, you've been in the clinical sites. You know that the technologist, when the image comes up, even though the computer has tried to make it the best looking image it could by using the histogram analysis and the lookup table, the tech will often fine-tune things. So he or she will move the mouse a little bit, and it either becomes a little brighter, a little dimmer, a little more contrasting, less contrasting. Basically, what the technologist is doing is he or she's changing the level and then the window width. So the window level, that brightness level, and then the width of different densities that would be around that level. If you have, remember, few density differences, then we've got a narrow window width. Narrow window width, not a lot of densities, high contrast. Now, if I open up the window and I let all those densities come in, lots of different densities, well, now I've got a very long scale of contrast, lots of steps. So I'd say that that's lower contrast. Now, I mentioned that the technologist will often make changes before they send that over or that image over in packs. Some departments don't like the technologists to do that very much. There's a reason for that. If we look at the screen, a radiologist can manipulate the data that is sent to them via packs. However, the more the technologist changes the original data before it's sent to packs, so the more the radiologist or the radiographer makes these different changes, the less information the radiologist has to work with. So many departments, when it comes up, if you've set the correct technical factors, chosen the correct anatomical part so that the correct histogram analysis can be done, and the correct lookup table was utilized, once the image comes up, a lot of departments don't like you to change or manipulate that image very much, okay? Because once again, as you, the radiographer, student radiographer, or the technologist that you're with, as they start manipulating a lot and then they send it over in packs, now the radiologist has less information that he or she can utilize. Contrast. Subject contrast is the range of differences in the intensity of the X-ray beam after it has been attenuated by the subject. Okay? So let's look at that again. The range of differences in the intensity of the beam as it has been attenuated by the subject. So the differences in intensities, amounts of photons. Why say subject? Whenever you hear the term subject, subject means the patient. The patient is your subject. He or she is the subject of the examination. So we've got subject contrast, subject detail, and so forth. So subject is patient. Your subject contrast is dependent on three things: the kilovoltage that is used, the amount of irradiated tissue, and the type of irradiated tissue. So let's look at these. So kilovoltage is the primary controller of subject contrast, as it controls the penetrating power of the beam. It's really determining how many photons are going to get through, how many photons are going to be absorbed, and how many are going to scatter. It controls that penetrating ability of the beam. It also influences the amount of scatter produced. What I need you to put into your brain is that the higher the kilovoltage, the more scatter, which is now going in a more forward direction, interacts with the image receptor. So high kVp, more scatter. Put that in your brain. High kVp, more scatter. And scatter is displayed radiographically as grays. So we want to keep those two things in mind. High kVp gives me more scatter reaching the image receptor, which means my image is going to be more gray. As the kVp is increased, scatter reaching the IR increases, yielding a more gray image. Thus, we can say a lower contrasting image. So high kVp, because it gives you more grays, is a low contrasting image. High kVp, low contrast, which then means that low kVp would be the opposite. It's going to give you high contrast. High kVp, more scatter, more gray, less black and white, which means that lots of grays, low contrast. Low kVp, you're going to have less scatter, less grays, more black and white, high contrast. So high kVp, low contrast, low kVp, high contrast. The amount of irradiated tissue. How does that influence contrast? When the difference between adjacent thicknesses of various body parts is great, the thicknesses of adjacent body parts is great, subject contrast is increased. Think of bone, which is very thick and hard, versus soft tissue. When little difference exists in the thickness of the adjacent body part, subject contrast is decreased. Like soft tissue only, if you were, let's think of a mammogram. Let's think of the breast itself. Breast, a lot of adipose fatty tissue that makes up the breast. Not a lot of subject contrast. Okay, there's no bone in there to give us any contrast. It's basically soft tissue only. We say that subject contrast is decreased. Even in the abdomen, if we think about, took away the bones, for example, took away the gas, for example, what would you have? You'd have a lot of grays, right? A lot of grays, and some of these grays would be so subtle they'd kind of be blending in with the other grays, and you wouldn't see very much. That too then would be a lower subject contrast. If we increase the thickness of the body part, or the size of the collimated field increases, so if we increase the thickness of the body part, think about going from an asthenic to a hypersthenic patient. Or we open up the field size. Let's go from an 8 by 10 to a 14 by 17. Either one of those two things is going to increase the amount of scatter. Thicker patients, more scatter. Larger field sizes, because you're irradiating more tissue, more scatter. So increased scatter reaching IR creates a grayer image. Okay, so the more thickness to the body part, which is going to give you more scatter, the larger field size, which is going to give you more scatter, either one of those, you're going to get a grayer image, which means that it's a low contrasting image, low contrast, lots of grays. Along those lines, too, if we talk about the irradiated material, when you talk about its type, when we talk about the type of irradiated material, we know that it's influenced by the atomic number of the material and the tissue's overall density, not radiographic density, but how thick the tissue is. When there's little difference in the atomic numbers of adjacent materials, subject contrast is decreased. Like in the abdomen, I just mentioned, the kidney kind of blends in with the other grays of the abdomen. That psoas muscle kind of blends in. You don't have a lot of subject contrast. In fact, if we wanted to assess the kidneys and all I had was a KUB, I might be able to see a stone, okay, some type of nephrolith. However, I'm not really going to see the internal workings, insides of the kidneys, for example, okay, or the tubes that bring the urine from the kidneys down to the bladder. In order to see that, I'm going to have to put contrast into the body that is not already there. And the way that we're going to do this is we're going to utilize contrast media. Contrast media, it's got a higher atomic number than the surrounding tissue would have. And because of that, it's going to absorb more radiation. So when we look at the middle radiograph here, we've got a AP, IVP exam projection. I can see that I'm seeing the insides of that kidney, the calyces, the renal pelvis. I'm seeing now the tubes that are going from the kidneys down to the bladder, the ureters, and now my the ureters I can also see draining into the bladder, and I can see the bladder very nicely. So without that contrast media, because the abdomen has a low subject contrast, we have to add contrast into the body in order to see the differences. Another example using barium would be the third radiograph there. Once again, on a plain KUB, I might see some gas patterns within the colon, but I'm not certainly going to see the different structures that make up the colon individually, meaning the flexures and the ascending and the descending portions, the sigmoid, rectal area. So I'm going to have to add contrast because that abdomen has low subject contrast. I've got to add contrast to make it more contrasting. And in this case, adding barium makes the colon much more apparent. When the difference in tissue density is great. Now, tissue density is how thick or tight those atoms are packed together. Subject contrast is increased. So as an example, bone tissue is a denser substance than lung tissue, right? Bones are a lot harder, a lot higher atomic numbers than lung tissue. So subject contrast between bone and lung tissue then is greater. Bone, soft tissue. An important point to note is anatomical structures of interest are visible only when sufficient contrast between the densities exists. Proper density IR exposure alone is not enough. You got to see the differences. So various densities on the radiograph must be discernible for the radiologist to make a proper diagnosis. Some radiologists prefer images with lower contrast. Some prefer images with greater contrast. Two technique systems allow for greater uniformity in many departments. Some departments, in fact most departments, use what's called a fixed KVP system, which permits images with lower contrast. With this type of a system, we use what's called the optimal KVP. The optimal KVP is the maximum KVP to be used for a given anatomical part that will produce images with appropriate contrast that are consistently within acceptable limits. So the highest KVP possible for the given part that will still give you good contrast. So when we use a fixed KVP system, the KVP is the same for each anatomical part, and we vary the mass. Over on the right is a chart. You've seen this before. Small extremities, we use about 50 to 60 kVp. Iodine-based contrast media, we don't want to go much above 69 because then you start penetrating right through the barium. Large extremities, 70. Skull, 80. Abdomen, ribs, 80. AP vertebral column, 80. Lateral vertebral column, we've got to increase because now it's a little bit thicker when we turn them on the side, 90. Chest, 120. And barium-based contrast media studies also at 120. Some departments use what's called a variable KVP system, and this permits images with higher contrast because you can bring down the kilovoltage more. In this case, because it's a variable KVP system, we change the KVP, but we keep the mass the same for a given part. So let's say the mass for a foot is 10 mass. Okay, we're going to keep that at 10 mass, and depending on the size of the foot, we're going to adjust the kilovoltage more or less. So fixed KVP systems, lower contrast because you're using the highest KVP that will still give you the correct contrast. So high KVP, lower contrast. Variable KVP, we can lower the kilovoltage, and whenever we lower the kilovoltage, we get a higher contrasting image. A visible change in contrast will not be perceived until the KVP is changed by 4 to 12%, depending on whatever kilovoltage range you're at. So if you're at 30 to 50, you're going to have to change your kilovoltage by about 4 to 5% or 1 to 3 kVp to see any change in contrast. 50 to 90, it would take about an 8 or 9% change, which is about 4 to 8 kVp. And if you're between 90 to 130, it would be a 10 to 12% change, 9 to 16 kVp change. So what does this mean? If I was using 120 kVp, okay, and I wanted to see a change in contrast, changing my kilovoltage by only 4 or 5, it's not going to cut it. You're not going to see that change. You've got to change that kVp by at least 9 to 16 kVp if you're in that kilovoltage range. So although contrast levels may be adjusted as a post-processing feature, which we adjust the window with, the correct kVp for a given anatomical part should still be chosen by the radiographer. The radiographer should still be setting up the correct technical factors, which include the correct kVp. Higher kVp, which is, remember, the optimum or optimal kVp, allows for a display of more anatomical data at the same time reducing patient dose. Remember, when we can up the kilovoltage, I can use less mass, right? So more photons are getting through the patient, less absorption, better patient protection. And at the same time, you're getting more anatomical data. Very, very, very important. Kilovoltage is the main controlling factor of radiographic contrast. As kVp increases, scatter reaching the IR increases because that radiation is in a more forward direction, and we call this radiation fog, allowing the image to be more gray, and therefore a lower contrasting image is created. So in the box here, if we increase the kVp, we increase the scatter reaching the IR, contrast goes down. If I decrease the kVp, low kVp, less scatter, image is more black and white, increased contrast. Influencing factors. We've got a few that really don't have any effect, like mass doesn't really have an effect, focal spot size, no effect, anode heel effect, no effect really on the contrast of the image. As far as distance is concerned, SID has no effect on contrast, whether at 40 or 72 inches. So none of these affect contrast. Now, mass definitely affected density, right, or IR exposure, but it's not going to be influencing the contrast of your image. Same thing with focal spot size, anode heel effect, or SID. Now, OID, though, this will have an effect, and it's because of what we call this air gap technique. So as the OID increases, more of the scatter misses the IR because you're at a further distance, and look at the image, look at the picture there, and notice the photons, they're missing the image receptor. They're coming off at angles that are allowing them to miss the image receptor. We call that the air gap technique. It's an alternative to using a grid. Most often you might see this as is pictured here with a shoot through of the lateral cervical spine. Now, filtration. Filtration does have an effect on contrast. We remember what we learned about density with filtration. Now let's think about contrast. What does contrast do? Or what does filtration do, I should say? Filtration hardens the beam. And what does this mean, hardens the beam? We're getting rid of the low energy photons. So remember, your beam is heterogeneous, lots of different energies. If I get rid of the low numbers, I'm left with the high numbers, a higher energy beam, higher average kVp. The greater the amount of filtration, the higher will be the average energy or kVp of the beam. Look at the X-ray emission spectrum down below. We studied this in the last course. And remember, when you had 2 millimeters, look at the amplitude or height. Look at the top of the continuous spectrum. Now, if I add 2 more, millimeters to give me 4 millimeters, added filtration. What happened? The quantity of the photons, the number of the photons went down. Remember, that's your y-axis. But remember, look at the top of your continuous spectrum. It did what? It shifted over to the right. What does that mean? I got a more energetic beam. I've got higher kVp photons now. Well, what do I remember about high kVp? High kVp gives me more scatter, right? More scatter reaching the IR. If I got more scatter, it's more gray. I decrease the contrast. So what can we say? As the amount of filtration increases, radiographic contrast decreases, more gray. Why? Higher average kilovoltage, higher average kilovoltage, more scatter, more gray, contrast goes down. Other factors, beam restriction. Whenever we increase the collimating to a smaller field size, we get less scatter. We can also say that this is increased radiographic contrast, right? Less scatter, more black and white. Anatomic part. If the anatomic part size gets bigger, we get more scatter. More scatter, more gray, contrast goes down. Grids. What's the whole job of a grid? A grid is there to remove scatter, right? So if I use a grid, I got less scatter reaching the IR, contrast goes up, right? More black and white. And I could take it a step further, and I could say that as we increase the grid ratio, remember the grid ratio is really how good of a job that grid can do at removing scatter. So as the grid ratios increase, the grid becomes more efficient, does a better job at removing scatter. Well, that's going to give me then what? A higher contrast, right? As grid ratios increase, the 16:1 grid absorbs more scatter compared to the 8:1 grid. So as that grid ratio goes up, 8:16, I get rid of more scatter, I get rid of more grays, contrast goes up. More black and white. And as far as image receptors are concerned, we're talking about the digital image receptor. Remember, the primary determinant for the scale of contrast is the post-processing histogram and LUT, that lookup table. So that histogram that you have, because of the technical factors that you set up, is going to be compared to the standard histogram in conjunction with the lookup table. You're going to get the right levels of density, IR exposure, and contrast.